Hello, and welcome to this special topic on updates on induction chemotherapy presented by Dr. Brian Kushner from Memorial Sloan Kettering. Dr. Kushner is a pioneer in developing the chemotherapy regimens that have been used in high-risk neuroblastoma for many decades. We're very happy that he's able to present on this update today. And following his presentation will be a few questions from Nick Bird from Solving Kids Cancer and myself, Donna Lubminski from Solving Kids Cancer.
Thank you, of course. Today's theme and message is reducing therapy and toxicity. And I just do need to acknowledge, we have a big neuroblastoma group here focusing on clinic and all sorts of aspects of treating neuroblastoma. I have no conflicts of interest. And I do want to note that our treatment program differs markedly from group-wide programs. We do recognize the drawbacks of single institutional results and experience. We're always looking everywhere for hoping to find better treatments. And again, the quest for knowledge and truth is a lifelong endeavor. Our definition of high-risk neuroblastoma, I should note, is standard, except for we do not consider MYCN non-amplified stage 3 greater than 12 months of age as high risk. And in terms of reducing toxicity, again, our approach is surgery alone for this small group of patients. It's worth noting that stage for stage, neuroblastoma actually is the best childhood cancer to have, because the localizer without MYCN amplification are cured with minimal therapy or surgery alone. And the metastatic to bone and bone marrow, which is virtually incurable with other pediatric solid tumors, is highly curable for neuroblastoma, perhaps in large part because of the efficacy of immunotherapy, and that's not available for the other childhood cancers. Neuroblastoma is super chemosensitive, which is really important, and dose responsive with extensive disease. Amazing how much disease tumor burden these children have. The efficacy of NAGD2 antibodies is really amazing as well. And it makes a difference, we'd say, between the going from what years ago the idea was to cure one child with high-risk neuroblastoma. Now it's, if we don't cure them, we wonder what went wrong. We think less chemotherapy without compromising survival is a realistic goal because of the advances with anti-GD2 antibodies, which in combination with GM-CSF are so effective against chemo-resistant neuroblastoma persisting in bones and bone marrow. And we do not view the need for myeloablative chemotherapy because we've had an extensive and unique experience showing no survival advantage with transplant in the era of anti-GD2 antibodies. And obviously I'll go into this a little bit. Drawbacks of current induction protocols or recent induction protocols, we would say, include ototoxicity, which can be very major even with 2 cycles of cisplatin, not to mention the high-dose carboplatin often used in the myeloablative or transplant regimens. Also, we have an issue with CNS relapse, and doxorubicin, which is so good systemically, does not penetrate into the CNS, and maybe reducing the use of doxorubicin might decrease the risk of CNS relapse. Here's a timeline overview of the whole treatment program at our center with 4 cycles of induction chemotherapy, no transplant, and going on to immunotherapy, local radiation therapy. We highlight certain improvements, we would say, in terms of our treatment, with a decrease in the number of cycles of induction chemotherapy, leading to less ototoxicity, no secondary leukemia, and possibly less infertility. In our new N9 protocol, with only 4 cycles of chemotherapy, we first see even less risk to hearing, kidneys, heart, liver, these major organs, and possibly less risk for CNS relapse. When we do radiation therapy for a long time, we've been using hyperfractionated, meaning twice daily dosing. That was based on findings in preclinical studies that showed that kind of scheduling less toxic to normal tissues. And we've been trying to reduce the standard dose of about 2,100, and we showed that we've gone to 1,800, and now we have a current trial with 1,500. I'll get into that a little bit more. And immunotherapy is so great, it has no long-term toxicities. And immunotherapy for us encompasses not only anti-GD2 antibody, but also a vaccine. Avoiding hearing aids with no cisplatin transplant is a very attractive goal. No secondary leukemia with less chemotherapy. We've already shown that that is realistic possibility. And better linear growth, meaning avoiding short stature with low, which is a distressing long-term side effect of radiation therapy, but hopefully with the lower dose, that problem will be minimized. The Goldie-Coldman hypothesis really drives a lot of our views in terms of induction, meaning that in this hypothesis, the idea is spontaneous mutations occur while tumor cells are in somebody, and they can just by chance confer drug resistance. So the number of drug-resistant clones is viewed to be proportional to tumor bulk, suggesting that rapid elimination of tumor cells might reduce the risk of emergence of new drug-resistant mutations. So we're really compulsive in getting high-dose high-dose regimens going as soon as possible during induction, meaning as soon as the counts recover, rather than just sticking to the kind of standard 21-day intervals. And we also aim to resect the tumor because as soon as possible, because chemotherapy is generally ineffective for eradicating tumor cells within large masses. The N9 induction includes, as I've said, 4 cycles, and the first cycles 1 and 4 involve high-dose cyclophosphamide with topotecan and vincristine. Cycle 2 involves ifosfamide, carboplatin, and etoposide, and cycle 3 is the standard high-dose cyclophosphamide, doxorubicin, or adriamycin. That's been widely used. We keep to 4 cycles because there's seems to be with high-dose and conventional chemotherapy, very minimal, modest further decrease in tumor burden beyond those 4 cycles. We like to use non-cross-resistant regimens, in other words, regimens that can kill tumor cells that are resistant to another combination. And again, aiming to reduce long-term toxicity and reduce the risk of CNS relapse. The rationale for high-dose cyclophosphamide, topotecan, and vincristine includes advantages over the doxorubicin being replaced by topotecan, which indeed can penetrate the blood-brain barrier, lack of toxicity to the major organs, and little, if any, acute toxicity such as mucositis. Advantages over the children's oncology group, Cyclo-Topo is twice the dosage of cyclophosphamide and a higher dosage of topotecan. We do have a lot of experience with this combination, which we developed some years ago, with major responses in ultra-high-risk patients being almost 1/3 of the time. It prevents, the high-dose cyclophosphamide helps prevent the formation of anti-drug antibodies that can impair the efficacy of immunotherapy, anti-GD2 antibody immunotherapy. The rationale for ICE, in other words, advantages over cisplatin and etoposide, include much less ototoxicity with the dosing of carboplatin that's used, and possibly better for preventing relapse in the CNS. And it might have better anti-neuroblastoma activity. There's some ancillary issues during induction. We do collect peripheral blood stem cells, even though we don't foresee doing standard myeloablative therapy with transplant, because the stem cells might be needed for other salvage therapies such as MIBG therapy. So we collect after cycle 3 or 4, meaning after a child's received a non-cross-resistant chemotherapy. So that might mean a less risk of occult neuroblastoma cell contamination in the collection. And we also, adds some extra days when you collect stem cells. So it avoids, by collecting after cycle 3 or 4, we avoid delaying the start of the non-cross-resistant chemotherapy. Again, this is all part of as per the Goldie-Coldman hypothesis of rapid elimination of tumor cells reduces the chance of drug-resistant chemotherapy, drug-resistant tumor cells. And again, surgery, we do it relatively soon after cycle 3. And again, this is to reduce the risk of spontaneous mutations occurring deep within these tumors. that might confer chemoresistance. And in past studies, we found that there was minimal further decrease in tumor size after 3 cycles of chemotherapy. Getting back to an overview of the timeline, again, I finished pretty much with some of the key aspects of the induction. But moving on, we do not do transplant, and that's an issue that normally comes after induction elsewhere, and I'll go into that. But we do have a huge experience with transplant. We did once view it as being a very exciting way to improve the outcome, and so we have had a big experience with it. And I should note that we have no bias towards any given type of therapy. We're looking to see what's best for our children. And the rationale for no transplant there's some important aspects to it. Transplant was once considered an exciting treatment for many solid tumors, but was stopped because of no benefit and much toxicity. But it was continued for neuroblastoma mainly because of 3 randomized studies that compared transplant to no transplant. And there's some drawbacks to those randomized trials because they happened a long time ago and might not be relevant now because they did not include key treatments used since at least 2010 for all high-risk neuroblastomas, namely dose-dense or dose-intensive induction, local radiation therapy, and immunotherapy. Additional drawbacks to those randomized studies, we'd say, is that at least in the first and third, they compared transplant to no or very little chemotherapy. And there was a different cytoreductive regimen in each, including total body radiation. And in fact, the updated results of one of the most sophisticated studies showed the same overall survival. And then there was a meta-analysis showing that transplant for high-risk neuroblastoma did not improve overall survival. And overall survival is well established as the gold standard for evaluating treatment efficacy. Additional reasons for that might argue against transplant is that it's unlikely that transplant chemotherapy will kill neuroblastoma cells that survive the high dose of chemotherapy used in induction. We would say this was supported by the COG 3973 trial, which compared purging to no purging and found that purging did not was not a prognostic factor. So suggesting that it was a myeloablative cytoreductive regimen itself that was inadequate for eradicating the tumor cells. Now, people still do transplant after chemotherapy and dinutuximab. Patients who have had resistant disease receive chemotherapy and dinutuximab, have a good response, and then go on to transplant. To us, that we would say that there's a lack of logic in that, in the sense of the tumor cells prove themselves to be chemoresistant, and transplant myeloablative therapy, the myeloablative therapy is just more chemotherapy. Now, of course, there's also the issue of toxicity, and there's immediate problems, notably, say, for liver or kidneys. There can be lethal complications, but there can be, the problems can lead to delay in starting key therapies like the radiation therapy and the antibody. And of course, there are the long-term problems of potential concerns about pulmonary fibrosis, nephrotoxicity, and infertility. Now, in terms of our own experience of transplant versus no transplant, we stopped doing transplant in almost 20 years ago because we'd found no benefit in the sequential studies that we carried out with transplant and without transplant. And since we stopped doing transplant, patients come to us post-transplant for 3F8, have come to us for antibody and GM-CSF, so we can compare the experience of our own patients who never went to transplant with the patients who referred to us for immunotherapy post-transplant. And we found that there was similar event-free survival and identical very long-term overall survival for stage 4 and MYCN amplified stage 2-3. The Sloan Kettering experience is somewhat unique because transplants used everywhere else except in Barcelona, where similar results were recently reported with antibody and no transplant. Now, just quickly about the antibody that we're using, it has was approved by the FDA, and all these antibodies are really exciting and very, very useful and helpful. and 2 have been FDA approved. There's certain advantages, certain reasons why we use naxitamab over dinutuximab. Very briefly, at least the naxitamab we can use 2.5 times the standard dose, and the dose response of antibody to tumor cells we found is in laboratory studies. So higher dosing is very attractive. It's also nice that it's done outpatient and only 3 doses per cycle. GM-CSF we use with the antibody, and it's unique dosing. We've always used it at a high dose based on laboratory studies that showed, again, a dose response with the GM-CSF. So we've been using high dose since we've started using it, GM-CSF in combination with the mouse antibody and now the humanized antibody. And subcutaneous injection versus intravenously, for example, or no GM-CSF is very advantageous for anti-tumor efficacy. Here's a nice illustrated example of what immunotherapy can do in terms of rapidly eradicating widespread disease. And it's routine in our patient population of patients with Curie scores, extensive persistent chemo-refractory disease with Curie scores over 10 or 20 to achieve complete responses after 2 cycles and clear the bone marrow as well. Now, but if our patients have soft tissue disease, not just bone and bone marrow, which is what antibody is super good for, we do use chemoimmunotherapy, meaning combining with irinotecan and temozolomide. Now, but there's some differences how we do it versus elsewhere. For example, here I'll point out the differences that the humanized antibody is infused with chemotherapy and with the GM-CSF, whereas the elsewhere the antibody is done with the chemotherapy, but the GM-CSF shots are done after that treatment and not with the antibody. Sure, the antibody stays in the system and might still be active. It might be beneficial in that setting to include the GM-CSF, but we overtly use the humanized antibody with both chemotherapy and the GM-CSF. And the antibody dose, again, is 2.5 times greater than the dinutuximab. And we also use a higher dose of temozolomide. Alkylating agents like temozolomide dose response is very well known, so higher doses very well recognized. So high doses would seem to be advantageous. Just very quickly, we do use dinutuximab and naxitamab with other chemotherapy in certain situations. But now, in terms of after the induction, we do I mentioned we don't do transplant, we do antibody, and we do radiation therapy virtually at the same time as antibody. In other words, we do a cycle of antibody and then immediately thereafter do the radiation therapy. Whereas elsewhere in the COG trials and elsewhere, for example, patients after transplant get radiation therapy and then get antibody. And we would say that it makes a little bit more sense to administer the antibody as soon as possible because of the concern about systemic disease. And here we're actually doing it virtually at the same time, both the antibody and the radiation therapy. I mentioned the hyperfractionated as a way to decrease toxicity, and sequential studies now we've already published that 18 gray is just as good as the 2100 standard, and we have an ongoing trial with 15 gray. And these number of days of treatment will make it very easy to do the radiation therapy between cycle 1 and cycle 2 of antibody. Radiation therapy is to the primary site, but it's also to other sites worrisome for relapse. Obviously, sites of persistent MIBG positivity, but we also often consider radiating sites that had bulky disease at diagnosis, such as the liver, or the skull, liver, or distant nodes. We view the idea that we take a look at our patient and say, what sites are we worried about relapse and can we do anything about it? And it often might be radiation therapy. We do follow antibody with, when we think somebody's received optimal amount of anti-GD2 antibody, we do include a vaccine that is aiming to further prolong the anti-neuroblastoma immunity by inducing the patient to maintain anti-neuroblastoma antibodies over months to years. And this treatment is, we found to be non-toxic and produce the biological effects that we want, which is to induce anti-neuroblastoma antibodies. But like with all of our treatments, we're always aiming to see how we can improve things. And we've come up with an additional strategy with the vaccine to study whether or not adding GM-CSF. I should mention that the glucan is taken because we found that in laboratory studies to augment antibody efficacy against tumor cells. And so we've added GM-CSF, and we have our ongoing trial now is randomizing to see whether GM-CSF helps or causes side effects that would be unwanted. Just to conclude, again, our overall guiding principle is to prepare for the future where chemotherapy is reduced and long-term adverse sequelae are avoided. We think less chemotherapy without compromising survival is already a realistic goal by virtue of the advances with anti-GD2 antibodies, which in combination with GM-CSF plus or minus chemotherapy are highly effective against chemo-resistant neuroblastoma persisting in bone and bone marrow. And the recent introduction of novel therapies that show promise of improving survival without any toxicity, including ALK inhibitors, DFMO, and the vaccine. And I'll end on that note.
Thank you, Dr. Kushner, for that incredible presentation. And so Nick and I now will ask some questions on behalf of the parents. So one of my initial questions to ask is, so how long has the 4-cycle induction been going? Is that just brand new, or has it been going for a while?
It's been going on for about almost a year and 3/4, almost 2 years.
Okay.
Yeah, and we actually, that's the formal trial. We actually treated some patients before not on a formal clinical trial. So actually, 2 years. I noted in some of those slides, the regimens that are used, we had a lot of experience with already. So we just, and I have to say, many patients have come to us, you might know, a lot of patients come to us in either self-referred just to continue therapy or because of problems. And there are many patients that induction included these cycles of chemotherapy, but not the whole. Usually, for example, after 2 rounds of COG, Cyclo-Topo might come to us instead of getting cisplatin-etoposide for the 3rd cycle, as per the COG trial, we'd do ICE. Or they came for problems with surgery, and after surgery, in the 5th cycle, instead of doing cisplatin-etoposide, we'd do ICE and CTV. A lot of patients come to us after receiving Kojak in Europe or elsewhere and have resistant disease, and we would treat them with the high-dose cyclophosphamide, topotecan, vincristine. They had not received the topotecan before and not received high doses, so it made a lot of sense to do that. And then they typically have surgery and then get either ICE or high-dose cyclophosphamide, doxorubicin, vincristine post-op, because again, very different from the moderate but rapidly administered agents in Kojak.
That's super helpful because you have such a variety that are coming to you at different points.
Yes.
I can see that you have to be, very mindful of what they've had. And so how many would you say per year start off with cycle 1 on the N9? Is that, I'm curious.
Yeah, so it's between 7 and 10.
Got it.
Yeah. Now, it's hard to get a newly diagnosed patient here. Usually, and we'll get a call if someone's newly diagnosed, but we'll say, get the treatment going as soon as possible home. That's in child's best interest. And then if you still want to come, you're certainly welcome to come. But we do, we always mention, emphasize that we're different, and that the standard of care elsewhere in the United States and in Europe, wherever they might be coming from, is different and might be better. They've never been compared. So if you're really, comfortable where you are, stick with where you are. The only patients that really, really want to come, we're here. We are here. but we're not trying to recruit patients, and we're not going to, we are always above board about the situation. So there are a number of patients that would get a cycle at home and then indeed follow through and come here.
Can I jump in?
Yes,
Donna?
please, Nick, please.
You mentioned a few times about the reduction or potential for reduction in risk of CNS relapse. I was just wondering if you could elaborate on exactly which change is behind that, and also is that an incidental kind of improvement in there, or was that actually one of the drivers for changing the induction regimen?
It's a driver, we really we've shown in the past that actually high dose myeloablative transplant that we were hoping would avoid that, did not successfully do that. That was a part of one of our myeloablative regimens was high dose thiotepa, topotecan, and carboplatin. But we're still looking to thinking that maybe early use of agents that cross the blood-brain barrier, get into the brain and spine, into the central nervous system, might prevent relapse. And so, again, the topotecan is not, topotecan penetrates the blood-brain barrier. So using the high-dose cyclophosphamide, topotecan, and vincristine is one of the reasons for that we like that regimen, is because it might, it's better than the cyclophosphamide, doxorubicin, vincristine. And the high dosing that we use compared to like COG, meaning like with twice the dose of cyclophosphamide and about 25% or higher dose of the topotecan, we think is advantageous for possibly reducing CNS relapse. And then ICE, iphosphate carboplatin-etoposide are really good for penetrating into the CNS. Cisplatin is okay, but we would postulate that the carboplatin is even better. So using, out of the 4 cycles, the 2 with Cyclo-Topo-Vcr high dosing, and the ICE, we hope that will decrease the CNS issue. Now, I can also say, look, CNS relapse is a devastating problem, but it is curable these days.
I was curious if you look so far at the first 2 cycles, if there's a comparable response rate. I know, the St. Jude trial looked at the first 2 cycles of topotecan and cyclophosphamide, which of course, like you mentioned, is much lower dose. And when they added antibody, they said they had an 80% response rate, as opposed to the COG's, what was it, 0532 had a 40% response rate. So curious if you looked at those response rates, or maybe that's not significant, because if you get to the goal of having, a CR or a very good partial response, maybe that's not important how fast that happens.
Yeah, no, I can't say that we have enough data yet on saying what the response is after 2 cycles. So I can't really say much about that. I can say that all of our patients after the 3rd cycle have had a good enough response to have their tumors resected.
That's great. So kind of a follow on that then, do you expect to have somewhere in the 20% rate of children who are not going to have a complete response or a very good partial response? I mean, is the goal just to go straight to antibody as you would anyway, and then have that take care of that metastatic disease? Do you kind of segment those out to see what their response and overall survival is compared to the kids that have those?
Yeah, so we do put a lot of stock on the antibody. So after 4 cycles of the induction, we uniformly go on to antibody, either antibody alone or antibody plus chemotherapy if there's any evidence of or concern about soft tissue residual. Sometimes there's a site, for example, a pleural nodule that was present at diagnosis. Maybe it's shrunk, but might not be that amenable to even radiation. So there's some concern about that site. So we might bias us toward doing the chemoimmunotherapy. Basically, the idea is the 4 cycles and then brainstorm about what we think makes the most sense given the child's clinical situation at diagnosis and subsequently. But and we're not ruling out the idea of doing another round or 2 of chemotherapy, but the general idea is that let's move on to antibody plus or minus chemotherapy, as long as plus the radiation therapy to the sites, the primary site, and other sites of concern.
So just on a similar theme.
So again, we're really reducing the duration of the treatments. That's one of those things in those timelines that comes out, if you think about it. Yeah. I'm sorry, go on.
No, it was along a similar thing. If you have patients who actually show limited or no response after 2 cycles, do you reassess at 2 cycles, and then do you continue regardless to 4 cycles, or do you think about changing at that point? And if so, also, do you look at some of the emerging evidence around the biology of tumors that might confer more chemo-resistant disease?
Good question, of course. No, we continue because, just for example, the 3rd cycle is different from the first 2. And we would say that 4 cycles is really a low number as it is. To abandon the chemotherapy at that point seems to us it would be premature. So I can't say that we would abandon the treatment unless there was some terrible toxicity that would, make it really unwise to continue. In terms of biology, I don't think there are any really powerful prognostic markers for high-risk neuroblastoma. Even MYCN amplification, those children are as curable as any others. Stage 2, 3 localized MYCN amplified, we'd say have, considered high risk, but have a better prognosis than the typical massive widespread disease with stage 4. So I can't say that we're breaking things down into standard high risk versus ultra high risk versus based on biology. There are some clinical factors, as a clinical judgment comes into play, and that's why we brainstorm about our children as they're going through the treatment, and at the end of the cycle 4, for example, we lay out a plan at diagnosis. But as we're going along, we keep discussing: is this make the most sense? Should we make an adjustment? Should we make a change that give a better chance for achieving our goal, which is cure with as few side effects as possible? That's very important for us to evaluate as we're going along.
Now, you mentioned on the future slide talking about the ALK inhibitors and DFMO vaccine. I'm curious about, number one, the ALK inhibitors, if that's included at all during induction. And then the other question is, what about using chemoimmunotherapy during induction? Is there any future thoughts on possibly incorporating that?
Okay, so both questions. The ALK inhibitors, we do not use the ALK inhibitors while they're getting those 4 cycles. We do it. We do add them if we do add them as appropriate if patients have the ALK mutation once they're starting antibody and so on. So we're happy to use lorlatinib, for example, in patients that have the ALK mutations. And I'm sorry, what the other?
Oh, any future idea about possibly chemoimmunotherapy during the infection?
So I have to say, going back, we some number of years ago, we actually did use antibody with N8, N7, and 8 induction after tumor resection with the late cycles of chemotherapy. We didn't see any advantage to doing that. So and with 4 cycles, getting to antibody is pretty quick. I can't remember exactly which cycle antibodies being used in some of the COG pilots, but it's pretty much, we would say, if anything, it just complicates matters. So we want to just do that chemotherapy as soon as possible, get the tumor out as soon as possible, and get to antibody as soon as possible. And as I say, sometimes it is with chemotherapy, depending on if the patients have just purely bone and bone marrow disease, we do just stick with the antibody. But if there's any, as I was saying before, if there's any concern about persistent soft tissue disease, then we're quick to use the irinotecan temozolomide, which is nice because those agents don't have long-term. I mean, if you get too many cycles of temozolomide, that's an alkylating agent that can lead to secondary leukemia, and that's a little bit of a criticism we have for the outside usage, sometimes up to 17 cycles. But be that as it may, that's another issue. But there's we're not really thinking about using antibody with those first couple of cycles of induction, especially, again, with a big mass. Yes, the antibody can work against the disease in the bone and bone marrow, but it also might be sucked up in the mass rather than maintaining high serum levels. So it's another kind of hypothetical reason not to use antibody before the main mass has been resected. That was the thinking that we had years ago when we would do a cycle of chemotherapy and literally and do antibody not the same days as the chemo, but literally the day after.
Now, quick question about lorlatinib. If you chose to use that during antibody, can they carry on with that during vaccine, or is that they have, if they elected to go on the vaccine?
We won't do it. We do not include it with the vaccine. Okay. Yeah. It's not approved. It's a tricky question. We've discussed it, but we would say that they've already gotten it. If they had the ALK mutation, they've already gotten it, lorlatinib for a while. So we don't feel bad about discontinuing it on the vaccine when they get to the vaccine.
I think that it's fascinating, and we could literally talk all day. But at some point, we're going to have to thank Dr. Kushner. Well,
thank you all for having me, and look, you folks have done so much, and I feel for you, with your losses and stuff, and we're just really, really working hard. I have to tell you, our team, to avoid the unhappy endings. And as I say, we've made the progress. I maybe think I mentioned it, didn't make it personal. What the idea was when I started several decades ago in the late 80s, my goal really honestly was to cure one child with the high-risk form. And now we really do not get it when we don't succeed. Now that includes children that relapse, patients who come to us in relapse, and patients we've detected relapse. We monitor our patients very closely, so if there's a relapse, we'll hopefully catch it early, not from symptoms, and we have a high cure rate of children that do relapse. And part of it is, also the efficacy of the chemoimmunotherapy. That was, I think is, we use irinotecan temozolomide and antibody. It's such a tolerable treatment and so effective. And other advances coming along. So onward and upward.
Yeah.
Really.
Always.
Always. Well, Dr. Kushner, thank you so much, not only for this presentation, but for your decades of focus on this disease. And it's very satisfying to know that your goal in the late 80s has been accomplished over and over and over many times. So thank you so much. And we really, really appreciate your time and all that you do.
You'll follow up anytime. Okay.
All right.
Sure.
Great.
Thanks very much.
Thank
Bye.
you.